this is Dr. Raghavi with another video for your rapid revision just before the exams. So in microbiology, it is quite boring, I understand. I've just tried to put it into slides of certain topics which are quite interesting and which actually need to be revised just before the exam. So we'll start with, in bacteria, the size or the structure of the bacterial cell wall also matters, because in that the capsule which contains certain enzymes can be responsible for the antibiotic resistance developed by the bacteria, as well as the bacterial pili which are involved in the conjugation reactions will also give antibiotic resistance to certain bacteria. So among the bacteria, the most commonly asked questions come into the following. So one is bacterial vaginosis. It is going to be the most common cause of abnormal vaginal discharge in any woman of childbearing age. So it is not per se an infection, but rather it is an overgrowth of anaerobic bacteria in the vagina. Fishy smelling discharge is typical. Bacterial change causes more alkaline environment with a rise in pH. That is, the pH is more than 4.5. It is not considered to be a sexually transmitted disease, and it is more common in those with intrauterine contraceptive device and smokers. Typically, treatment is via oral metronidazole for about 7 days. Usually the dose is 400 mg twice daily. So in the diagnostic criteria of bacterial vaginosis, the most commonly asked one is AMSELS. So to confirm BV or bacterial vaginosis through AMSELS criteria, at least 3 out of the following 4 should be present. There should be a thin, white, homogeneous discharge. Clue cells on microscopy should be noted. So clue cells are going to be the vaginal epithelial cells which are surrounded by the bacteria. And the pH of the vaginal fluid should be alkaline, that is, it should be more than 4.5, and there would be a release of a fishy odor on ordering potassium hydroxide. The other criteria are Hay or Eisen's criteria, where the vaginal exudate is graded into 3, grade 1, 2 and grade 3. Grade 1 is normal, where lactobacillus morphotypes predominate as in a normal individual. Grade 2 intermediate, mixed flora with some lactobacilli present, but Gardnerella or Mobiluncus morphotypes also present. Grade 3 is predominantly Gardnerella and or Mobiluncus, while the lactobacilli are very few or absent. So as you can see, the cause of bacterial vaginosis or most common cause of bacterial vaginosis is going to be an overgrowth of Gardnerella species. The other score that is used in bacterial vaginosis is Nugent score. It estimates the relative proportions of bacterial morphotypes to give a score between 0 to 10. That is, it compares the percentage of Gardnerella to the lactobacilli. So if they are less, like less than 4, it is normal. 4 to 6 is intermediate, and more than 6 Nugent score indicates that it is bacterial vaginosis. Done? Fine. So again, the other commonest question comes usually from Listeriosis. It is caused by Listeria monocytogenes, and usually the question carries a word that the women had soft cheeses or cold meats on a picnic. So the fetus can be affected via transplacental or ascending spread, and incidence in pregnancy is about 12 per 100,000. It is 20 times more likely in pregnancy than in general population. So typically the adults have a mild illness, so it can be unnoticed in the mother, but she would be presenting to you with preterm labor, abdominal pain due to chorioamnitis and placental necrosis and granuloma formation. So miscarriage, stillbirth and meningitis can result from Listeria infection during pregnancy. The fetal mortality rate is about 20 to 30%. However, some sources say it can even be up to 50%. Treatment is typically with amoxicillin for about 2 to 3 weeks. So any question which expects Listeriosis as an answer is going to have either that pregnant woman presented with preterm labor, or she had a history of intake of soft cheeses or cold meats, and there might be some mention of greenish amniotic fluid. Okay, so now we'll go to a question. A 50-year-old has ongoing pelvic pain. She has had an intrauterine coil for the last 8 years. She has a pelvic mass on examination, and histological sampling of the mass at laparoscopy shows a suppurative and granulomatous inflammatory process with the presence of sulfur granules. So which is the most likely causative agent? So the points presence of intrauterine coil and a suppurative granulomatous inflammatory mass with sulfur granules is typical of actinomyces. So actinomyces, they are gram-positive bacteria. It is a commensal of colon, mouth and vagina. It is the commonest cause of actinomycosis, a chronic, suppurative and granulomatous inflammatory infection. The diagnosis of pelvic actinomycosis is usually made from histological samples taken during surgery and has been associated with intrauterine contraceptive devices which have been in situ for long periods of time. The presence of sulfur granules is characteristic of actinomycosis infection. One more point that I wanted to stress is if a patient with IUD has PID, it is not necessary to immediately remove the intrauterine device. Rather, you just give them antibiotic and wait for 48 hours. If there is no clinical improvement after 48 hours of antibiotics, then you can consider removal of the coil. An 18-year-old woman presents to a sexual health clinic requesting a sexually transmitted infection screen. She is asymptomatic. However, she is concerned as her boyfriend is complaining of dysuria, penile discharge and scrotal pain. So what is the most likely cause of his symptoms? So in women, usually chlamydia might be asymptomatic, while in males it is symptomatic infection. So here, most common sexually transmitted infection being chlamydia. The answer is C, Chlamydia trachomatis. So chlamydia, the boyfriend symptoms are suggestive of urethritis, which from the list of given options, that is amidst actinomycosis or Candida albicans, Toxoplasma and Treponema, is most likely to be due to chlamydia. It is caused by Chlamydia trachomatis, a gram-negative intracellular bacterium which infects the squamous columnar epithelial cells. Chlamydia infection is often asymptomatic, especially in women. They may notice a postcoital or intermenstrual bleeding, dysuria and low abdominal pain, whereas men may experience dysuria, penile discharge and scrotal pain. Chlamydia infection is the commonest cause of pelvic inflammatory disease and may go on to cause subfertility and increased risk of ectopic pregnancy. The treatment of chlamydia is usually via azithromycin or third generation cephalosporins. The recent favorite of RCOG is Syphilis. So, causative organism is Treponema pallidum. It is a long, slender coil bacterium. The other strains which cause endemic non-venereal syphilis, Yas and Pinta, are Treponema pallidum pertinue and Pinta by Treponema pallidum caratine. So, syphilis stages is a primary syphilis where there is chancre. So, it can be early, latent or tertiary. So, early includes primary and secondary. Primary is the initial infection. Secondary infection follows primary infection and it usually presents with fever, rash and condyloma lata. Then there is a quiescent period where the patient does not manifest any symptoms but serology is positive. Early latent syphilis is less than 1 year of the primary infection. Then the patient goes into a late latent phase. So tertiary usually occurs 20 years later, most unlikely in the obstetric population that we will encounter. It will present with neurosyphilis or cardiac symptoms. So serological test for syphilis, the most commonest is the venereal disease laboratory test, that is the VDRL. If it is positive, then it is a non-specific test. That is, there are two kinds of serological tests for syphilis. One is Treponema pallidum specific and the other one is treponemal non-specific. So VDRL is one of the non-specific tests and it may give false positive with certain other infections also. So if any patient comes to you with VDRL positive, confirm with a treponemal specific, TPPA or TPHA, and always do a repeat sample for enzyme immunoassay. So then also do a rapid plasma reagent testing or RPR for establishing titers and follow-up for treatment. Usually RPR titers become undetectable after completion of treatment. Repeat screening 3 monthly in high-risk groups. So management on the baby first, syphilis in a mother can lead to intrauterine growth restriction, hepatosplenomegaly, preterm, stillbirth or even hydrops. So the congenital syphilis is a baby born with syphilis and the baby is going to present with skin rashes, jaundice, meningitis and bloody discharge from the nose. What we call as Hutchinson's triad is keratitis, 8th nerve deafness with notched incisors. So management of syphilis is quite simple. Usually the management is based upon whether that is an early disease or late disease and in what trimester of pregnancy. So early disease, it is single in both first and second trimesters. It is a single dose of injection benzathine penicillin 2.4 million IM. Late disease, irrespective of the trimester, you are going to give 3 doses of benzathine penicillin at 1 week intervals. If the patient is allergic to penicillin, then the treatment of choice is injection cephalosporin 500 mg intramuscular for 10 days. Not allergic but still unable to tolerate intramuscular injections, go for oral amoxicillin plus probenecid 4 times a day for 2 weeks. If there is any active ulcer in genitals, a patient with syphilis should be delivered by a lower segment cesarean section. Always go for partner screening at a gum clinic referral. Postpartum, make sure there is a neonatal review for the baby. Fine. So now this I have given few tables which would help you to revise. So most common questions are from the gram nature of the bacteria and also whether they are in chains, clusters or pairs. So gram positive pairs, which are cocci, most commonly it is going to be Streptococcus pneumoniae. Gram positive cocci occurring in clusters is aureus, and a very common question wherein a woman presenting to you with vaginal discharge, and on examination gram staining of the discharge you are able to identify gram negative cocci in pairs, then the answer is going to be Neisseria gonorrhoeae. So I'd like you to go through these tables and use them for your revision. So this is again another table showing some common infections caused by all these important organisms. Usually there is always a question on staff either regarding food poisoning or urinary tract infections and gas organisms which are responsible for systemic sepsis. So among the gram-positive bacilli, most commonly asked is either Listeria or Clostridium tetani, and the cause of gas gangrene is another question. So gas gangrene is caused by Clostridium perfringens. So gram-negative, as we already saw, Neisseria gonorrhoeae is one of the most commonly asked. The rest are just remember the names. It might be one of the options. Like you are given 4 options, like which of the following are gram-negative cocci except, and maybe remembering these would help. So again we are going on to the gram-negative bacilli. I am not going to read through all of this. This I just put up because it would be helpful for you to read. Like once you just go through this video and take screenshots or whatever of this tabular column, just going through it would be helpful for you to finish the exam. And before I finish off bacteria, there is something questions are asked regarding the bacterial endotoxins and exotoxins. So exotoxins are produced by both gram positive and gram negative. Exotoxins, exo are extracellular, so they are released out of the cell. Examples include tetanus toxin, cholera symptoms, E. coli and Shigella. So since they are released out of the cell, they are susceptible to antibodies and are destroyed by heating. On the other hand, endotoxins are through gram-negative organisms. They are the structural molecule of the gram-negative bacterial cell wall released on cell death. So usually these lipopolysaccharides released by these organisms causing systemic sepsis are example of endotoxins. So they are not susceptible to heat and they have limited effect by antibodies. Fine, so that's all about bacteria. Now I'm moving on to virus. Among the virus, herpes simplex type 1 and 2. Usually type 2 accounts for 70% of the genital herpes infections. It is a double standard DNA virus. I do have another table which is going to give you information regarding which virus is DNA, which virus is an RNA virus, and which are double standard and which are single standard. So HSV infection may be transmitted to the neonates. Transmission is typically due to the neonate coming into contact with infected maternal secretions. So highest risk with primary herpes infection within 6 weeks of delivery. So viral shedding can occur after lesions have healed. So management is neonatal herpes is very rare. In UK the incidence is 3 in 100,000 live births, but it is serious. There are 3 types of neonatal herpes: restricted to skin or superficial infection, which is the least severe form. Then you have a CNS infection and a disseminated infection. CNS has a mortality with antiviral treatment of about 6%, with the 70% ending up with neurological sequelae, and disseminated infection has a very high mortality of about 30%, with 17% of the surviving infants having neurological sequelae. Management, first and second trimester acquisition. Initial episode, treat with acyclovir 400 mg TDS for 5 days. Following first or second trimester acquisition, daily suppressive dose of 400 mg TDS from 36 weeks of gestation reduces HSV lesion at term and hence a need for cesarean section. Third trimester, if it is primary syphilis in third trimester, the mode of delivery is going to be LSCS. But however, when you initiate acyclovir in third trimester, continue till delivery. The dose is the same, 400 mg TDS. Okay, so we have a question with an antenatal screening of a 25-year-old patient is suggestive of hepatitis B infection. Her serology shows HBsAg positive with positive HBeAg, but however anti-HBe antibodies and anti-HBs antibodies are negative, but however total anti-HBs are positive. So which of the following is most likely to represent our hepatitis B status? So if it is a recent infection, then the total anti-HB, it can be, depending upon the given scenario, it can be either a recent infection or a chronic infection with high infectivity. So whenever there is presence of both HBs positivity in HBsAg with anti-HBc Ag also positive, it is an chronic anti-active HBV infection. So as you can see in this question, there is anti-HBc is positive along with HBsAg positivity. The presence of HBe antigen positive indicates that it has high infectivity. So the answer is going to be chronic infection with high infectivity. Fine. So in in hepatitis B infections, whenever there is all of this are negative, like hepatitis B, hepatitis S, hepatitis B surface antigen negative, anti-HBc is negative, anti-HBs is negative, it indicates the individual is susceptible, needs vaccination. Once the individual is vaccinated, then anti-HBs becomes positive. On a resolving infection, the marker of acute infection, namely hepatitis B surface antigen, is negative, while the anti-HBc and anti-HBs are positive. On the other hand, in a chronic infection, we have HBsAg positive with anti-HBc positive. But however, the anti-HBs antibodies are negative. However, if there is HBsAg negative with core antibody positive and HBs antibody negative, it can be a distant resolved infection, or if the individual is recovering from acute infection, or it can be a false positive also. Just revise this table once or twice. You'll always have a question on hepatitis B, either regarding something like where you are given the serotype and then asked to identify in what phase of infection the patient is present, or you'll be given a phase like in a vaccinated individual, what can be the serotype. So just make sure you remember this table. So other common infection that is asked is cytomegalovirus. More than 50% of women are seropositive, and congenital CME infection refers to infection during the perinatal period and tends to affect mothers who have their first CME infection during pregnancy. The vertical transmission rate is approximately 40%, of which 10% of infected individuals will be symptomatic. Transmission can also occur via breast milk. Features of congenital CME infection: sensorineural hearing loss. It is the most commonest cause of sensorineural hearing loss. It can also cause visual impairment, microcephaly, low birth weight, seizures, cerebral palsy, hepatosplenomegaly, and thrombocytopenia. Okay, so we have a 32-year-old primary school teacher who is 16 weeks pregnant. She is seen in the antenatal clinic where she reports a maculopapular rash and coryzal symptoms. So the general practitioner has already sent serology and you just review the result. So it shows rubella IgG positive, which indicates she is immune to rubella. Rubella IgM is negative, means there is no active infection. Parvovirus B19 IgG is negative, that means she is not immune to parvovirus B19, like she hasn't had a previous infection. And parvovirus B19 IgM is positive, which shows there is a recent infection of parvovirus. So the answer is going to be D. The woman is having a recent infection with parvovirus B19. So what does this do? So the presence of IgG always suggests previous exposure to an antigen, whether in the form of a vaccine or through contracting the virus. Development of IgM is an acute event and occurs after exposure to the antigen. In this patient, the serology results for rubella suggest either previous exposure or immunization, and there is no evidence of any acute infection. Specific parvovirus B19 serology indicate recent infection with the parvovirus B19, and parvovirus B19 has been implicated with pregnancy loss and in ongoing pregnancies with fetal hydrops and anemia. Okay, so the viruses which can cause damage to fetus include rubella, CMV, varicella. While parvovirus, rather than birth defects, it can cause persistent infection and fetal death in the form of anemia and hydrops. HIV-1 and HIV-2, they do not cause any birth defects, but obviously it can cause infection, fetal death. Hepatitis C, we do not know whether it can cause fetal death, but however, persistent infection can be seen. Polio, fetal death can occur, birth defects and persistent infections are not yet identified. Japanese encephalitis, we do not know. And Lassa fever, it does not cause any birth defects or persistent infection in the fetus. So we need to be aware of only rubella, CMV and varicella during pregnancy. So viruses, I just wanted to tell you the classification. The most common DNA viruses include herpes simplex 1 and 2, varicella, cytomegalovirus, hepatitis B, human papillomavirus and Epstein-Barr virus. The only single standard DNA virus that is going to come in your exam is parvo. Parvo is like a parvo virus, so it is going to be solo or single standard. RNA viruses, all of them are mostly single standard except rotavirus. Rota, remember, it is like getting rotated again and again so that it becomes double. It keeps on multiplying, remember it that way. Or rota causes diarrhea, R to D, so therefore it is a double standard virus. But otherwise, all RNA viruses that you are going to mostly come across are going to be single standard. And you also remember all hepatitis viruses are single standard RNA virus except hepatitis B, which is like a very important topic and very big topic, so it is discussed in detail. So therefore hepatitis B is a DNA virus and it is a double standard virus. Fine. So viruses associated with malignancies. Epstein-Barr virus can cause Burkitt's lymphoma and B-cell lymphoma, especially when there is a coexisting HIV infection. It can also cause nasopharyngeal carcinoma. Human papillomavirus can cause cervical cancer, and the vaccinations for cervical cancer, we have Gardasil as well as Cervarix, and the recent nanovalent cervical cancer vaccine, which gives protection against 9 different species of HPV, is also there. The vaccine doses at less than 11 to 12 years of age, just 2 doses are given, and after 12 years of age till 45, an individual requires 3 doses at 0, 1 and 6 monthly intervals. Hepatitis B can cause hepatocellular cancer, and again human herpes virus 8 can cause Kaposi sarcoma, especially in an individual with human immunodeficiency viral infection. HTLV causes adult T-cell leukemia. So before we finish, this is again an important question. Among the types of vaccines, just remember polio, mumps, measles, rubella, yellow fever and varicella are live vaccines contraindicated in pregnancy. Killed vaccines are polio, hepatitis A, rabies and cholera. Rabies vaccine can be given in pregnancy provided that the benefit outweighs the risk. Toxoids, diphtheria and tetanus, so they are safe in pregnancy. So vaccines from subunit of the organism include your hepatitis B viral vaccines, Neisseria, Streptococcus pneumoniae, pertussis and influenza. Influenza vaccine is again recommended in all pregnant women. So that's all. I hope this was useful to you. Thank you.